Thank you. It's great to see so many familiar names. I wore my UK blue shirt for this presentation. And I think I include the Northwestern reference because I actually knew Dr. John Lyons. We were colleagues at Northwestern University way back. So that tells you just, yes, cats. Northwestern was Wildcats as well. That tells you how far we go back. So I'm really happy to be here. I am an economist by training, but I'm a nice economist. And so I welcome a discussion on these items. I want to spend just a little bit of time talking about, how healthcare and the healthcare system in the US has developed over time and how it has really not set us up for success in a person-centered care world. So I'm going to go ahead and share my screen. And also, if you have questions, go ahead and put them in the chat. We will have some time for, sort of a verbal back and forth, but if you don't want to lose track of those questions, please put them in the chat and we'll try to get to them towards the end, if that works out for you. So the economics of health, and in a minute, I'm going to sort of distinguish between health and healthcare and why our healthcare system is failing so many people. Just before we get started, I want to outline our learning objectives. After this session, I hope that you will have an understanding of the history and development of our deficit-based healthcare system, and I'll talk a bit more about that. Eventually, you will be able to identify the consequences of that approach for population health, something that I think all of you care about a lot. And then we'll spend a little bit of time thinking about and hopefully discussing how we can devise and recommend more holistic approaches to health and healthcare. Okay, so before we get going, I want to sort of lay some foundational items. And the first is thinking about what is health. I know this is kind of an economisty thing to think about, but I want to talk about that for just a minute. The World Health Organization has a lovely definition that I think is very helpful. Health is the complete state of physical, mental, I'm going to have to make people smaller, you're covering my slides. Complete state of physical, mental, and social well-being, and not merely the absence of disease and infirmity. And so they're very much contrasting the way that many people think about it is the lack of health is when you have disease, but saying no, instead it's this positive forward looking state where you have a state of well-being in all of its facets. Okay. Ooh. Let's see if I can keep going. There we go. So also as a foundation, I want to provide a little bit of history. And I actually had quite a bit of fun putting together this talk, thinking about how our history has led us to this point. So in the 1700s, yes, the founding of the United States, when none of us were around, health care was extremely rudimentary. And that was for a number of reasons. One, it was because of who actually immigrated to the new world, the new country. And hint, it wasn't a lot of physicians and upper class people. It was very much the working, those escaping, persecution, etc., coming to the land of opportunity. And a lot of young families. And so there was a lot of childbirth and not a lot of physicians. And so instead, what we had was a lot of women taking care of the sick, especially those in childbirth. But remarkably, not remarkably, mortality was extremely high, especially for infants and young children. There was a lot of communicable diseases. And in essence, there was virtually no public health. Now, that was sort of universally true in the world, but it was especially true in the United States. It was very frontier-like. Still, there were a few things that were developing during the 1700s. Our first medical society in Boston was actually founded in 1735. Our first hospital, General Hospital, was founded in 1750 in Philadelphia. And then in addition, our first medical college, also in Philadelphia in 1765, all before the actual founding of the United States. In the 1800s, there was further progress, as one would hope. However, it's notable more soldiers died of disease in fighting the Civil War than actual fighting in the Civil War. It was pretty awful. And we hear of shortages of medical supplies, shortages of physicians/surgeons, as many of them were called, and a general lack of hygiene, crowded conditions, and just epidemics. So we had lots of soldiers staying close together, and epidemics just spread like wildfire. Measles, mumps, chickenpox, you name it. And then also, so not only all these communicable diseases, which actually killed more soldiers than their battle injuries, but there were a lot of battle injuries. And so there was, by necessity, significant progress in surgical techniques, especially in the North. So a time of great need of healthcare and some development of healthcare to respond to that need. Specifically, I list some dates down here at the bottom that are kind of interesting. During the Civil War, there was development of floating hospitals to address battle-related needs. And then shortly after, within the 20 years after the end of the Civil War, we saw that the U.S. Army established the hospital corps, which was a sort of one of the earliest systems of hospitals. The Library of the Surgeon General's office established a rudimentary information system where they kept information on treatments of particular conditions and diseases and what actually worked. So some of the first evidence base. And then finally, towards the end of the 1800s, we do see the American Medical Association start to gain momentum and membership. All right, and then we come to the 1900s. And that's actually where we just see a lot of rapid movement in our healthcare system in the United States. Part of this was driven by the Industrial Revolution, where we had a lot more factories, where people would go to work and unfortunately get hurt very badly because there was very little safety. And soon we had unions who were very focused on worker health and workplace protections to protect health. And that was a significant driver of our healthcare system. Over the years, there were a lot of failed attempts to try to provide health-related benefits to the working class and low-income citizens. And it really wasn't until 1965 that we saw Medicaid established. You'll see that date over there on the right. So during the 1900s, we start to see some protections, some sort of systematic protections, the war risk insurance for military in case of death or injury, so protecting the soldier if they were injured, the family if there was a death. Interestingly, in 1923 was the first Blue Cross Blue Shield. It was established by the Baylor hospitals in Dallas for a union for unionized teachers. So that was very interesting, first Blue Cross. In 1935, we see one of the first major US-wide public programs, the Social Security Act, providing support for elderly, unemployed, and disabled. It was not healthcare, but it was really a precursor to thinking about these universal protections. In 42, interestingly, with World War II, there were a lot of wages were frozen to sort of protect industry, and employers, in order to attract employees, began to offer health insurance as an alternative because they weren't allowed to offer higher wages. And then in the 40s and 50s, we start to actually see some real progress in effective medical care. Prior to that, there was high death rates, and we didn't need a lot of insurance because we just didn't really know what to do to protect health. But we start to see penicillin, so antibiotics and vaccines, which really made significant improvements in health, so that there was now impactful medical care that we had to pay for. And so consequently, you see that the role of health insurance starts to grow in the 1900s, and we start seeing this sort of prices going up, health insurance going up, prices going up. And I'll talk a little bit more about that in just a second. But a very interesting development of the healthcare system in the US over these 3 centuries. And I would say that our deficit-based healthcare system is born. And what do I mean by that? Well, providers, especially physicians, played a strong role in shaping our US healthcare system. And our system became physician and hospital centric. Patients flow in and the providers treat them. They sit there centrally and the patients come to them for the most part. There was very much a focus on fixing something when it goes wrong, not prevention. And in addition, and I don't mean to offend any providers, but there was a strong focus on protecting the financial health of physicians and hospitals. And a lot of that was built into the way that we paid for healthcare through the insurance and then also through fee-for-service payment. Oh, sorry, let's see if I can get that. Yes, so I would call that an illness model. So when you are sick, you must come in, we will take care of you, and you can go back to your community, as opposed to providers going out into the community. Very little of that. Okay, in addition, again, a deficit healthcare system is born. Insurance is brought into being to protect finances, but in a perverse way, it actually begins to fuel cost increases. So reimbursement initially was very much fee for service based on cost. If you do a service, you get paid for that service. There is no focus on whether it's the right service, whether it is a high quality service, whether it is simply you did this service and this is what we're going to pay you for it. And the payment for many, many years was simply based on charges, a version of charges. And so that actually, in many ways, fueled what many economists call a medical arms race. If you have insurance and you can go to any provider and they will all be paid, how will you choose which provider to go to? Well, you would do it based on what you think is the best. And if you don't totally understand the difference in quality between different providers, you will look at who has the nicest facility, who has the latest MRI machine, who is advertising more. So providers began to compete for patients in a cost escalating way. So we see that medical care inflation was very high over the 60s, 70s, and 80s. And then in response to that, insurance companies and Medicare and Medicaid focused on cost control, but they developed this concept called medical necessity. And once again, you see this very deficit-oriented language and concept just permeating our healthcare system. Again, an illness model. Medical necessity says, how ill are you? That's when I'm going to decide to pay and how much I will pay. Okay, so this deficit-based, this illness-based healthcare system has a lot of consequences for the health of our populations. First of all, I'd focus on how it just creates a lot of barriers to care. If patients must come in to their provider to get the care that they need, then any patients who are living in rural areas, patients who have, probably well-founded mistrust of the healthcare system aren't going to come in. Patients who lack social support, patients who are low income, patients who lack transportation. I could go on and on. All of them are necessarily kept out of getting the care that they need. And the providers are not flowing out to them. They're staying where the patients come to them. And so this approach necessarily results in disparities because any populations that experience barriers are going to get less health care and therefore have worse health outcomes. Another thing that we can see, the consequence for the health of populations, is that this deficit-based system fails to protect health and it disables individuals. So what do I mean by that? Well, the payment is only for medical necessity. If you are somehow unable to establish that the care you're seeking fits in the definition of medical necessity, and I'm pretty sure all of us have experienced that at one point or another, then you don't get that care. This system implies that health is the absence of illness. So, taking seeking care to protect health, to protect the strength of the individual is not well supported in this system. Very limited emphasis on health protection and prevention. I'll talk a bit more about that in a minute. And I would argue that this system disables the individual person as the central decision maker in building and maintaining their health. Now, are there people who are empowered to look out for themselves? Absolutely, bravo. But does this system create incentives for that? Absolutely not. We all know many folks who have faced great barriers and are told what they need, as opposed to centering the individual and their family and support in deciding what will support their health. Okay, so let's so we were down at the individual level. Let's step up here just for a minute to look at the consequences of our healthcare system. We are now in a position in the United States where we spend an inordinate amount of money on healthcare, probably about twice as much as the next highest country, which is Canada. So, for example, some recent data. I always love to show some numbers so that you can see what I'm talking about. Right now, we spend about $8,000 per person for single health insurance coverage, employer-based health insurance, which is the predominant form of health insurance for the 65 and under, and about $22,000 a year. Now, these numbers are a little bit old, but about $22,000 a year for family coverage. That is an enormous amount of money per year, and again, much higher than other developed countries. And why is that so expensive? Well, here are some examples of what we spend our healthcare dollar on. For example, $38,000 for a hospital-acquired infection. So hospital-acquired infections are a very interesting case of when something has kind of gone wrong in a hospital after a surgery or after some sort of treatment. Very expensive and very unpatient-centered, very painful. Nobody wants this to happen. We spend about $50,000 a year in the last year of life for Medicare enrollees, arguably a time when we should be focusing on quality of life, and often we are focused on that deficit that we could address with some medical care, which may or may not be quality of life enhancing, and we spend a lot of money on it. $60,000 a year for a stem cell transplant. $135,000 a year for $135,000 for a lung transplant. So we have become very, very good at doing heroic, life-saving measures that are very expensive. And so our healthcare costs just keep rising, and our system keeps creating the incentives for doing more of this, which may or may not be very person-centered. Okay, so what do we get for that? Well, unfortunately, if you look at some of the population level measures of health outcomes for our country, we have very poor health outcomes. So this is life expectancy at birth, and I've highlighted here the United States. Of all these high-income countries, we spend the most, and our life expectancy is number 30. way behind many, many other countries, and very close to the Czech Republic, Estonia, Turkey, Poland. Okay. So with all that money, we are not actually raising average population level outcomes. Another aspect of that, infant mortality. I tend to believe that society is as good as the impact they make on our most vulnerable, and infants certainly fit into that category. Our infant mortality, we are number 45 out of these countries. So you cannot argue that, one, we spend the most, about double of any other country, and we get by far some of the worst outcomes of these high-income countries. So our system isn't working. So now I'll be a little economist financy and talk about some of the solutions that have been proposed over the years, and think about how much they may have helped. One of the first major reforms in our health system after insurance, insurance basically came into effect with Medicare and Medicaid in 1965. And by the mid-70s, we had a lot of very large commercial Blue Cross types of plans covering individuals. By the 80s, we knew that costs were out of control and we needed to do something about that. So one of the bigger things that was implemented was called prospective payment. And what that said is we are not going to simply have the provider, the hospital, whatever, tell us that they did the service and we pay them according to a fee schedule. Instead, we're going to think about what the diagnosis for that patient was. Prospective payment focused mostly on hospitals where we spend a lot of money. We'll look at what the patient's diagnosis was, what the surgery was that they needed, and we will put patients in these buckets, I'll call them, called diagnosis-related groups. And then we will pay essentially the same amount for each patient who's in that same DRG. So if that patient needed a cardiac bypass graft, and they fit in a particular DRG, an uncomplicated cabbage, as we would call it, then the payment was essentially the same no matter where that patient got their care. And the incentive for that was limiting the incentive for providers to keep them for 20 days and give them every medication, every rehab, everything they could possibly fit into that bill before letting them go home. Instead, and sometimes a little bit horrifyingly, the incentive was to provide the surgery and a very minimal follow-up care and send the patient home. We used to call it quicker and sicker. So it certainly had the impact of having hospitals minimize the care that was provided and control costs because they only got paid a certain amount, but it also had some pretty negative consequences for some of those patients. This placed most of the risk on the provider, and their incentive was to minimize cost for a particular treatment or diagnosis. So it did rein in costs, but I would argue that it remained very deficit-oriented. Do you need this procedure? Then come in and we can give it to you, instead of focusing on what might support the long-term health of somebody. No focus on outcomes of care, no focus on patient-centered wellness and quality of life. So another solution, a more recent solution, one that I have studied extensively and happy to chat with you about, is value-based payment. What is value-based payment, and is it the solution? Well, value-based payment expands the focus of reimbursement beyond just, do we think you need this service? Okay, we're going to provide this service, and we'll get paid a certain amount for it. But it expands it to include measures of quality of care and patient outcomes. So, for example, hospital value-based payment has has very much focused on the prevention of what we call never events. A never event might be a hospital-acquired infection. We talked about how expensive those were and how unpatient-centered they were. It focuses on prevention of inpatient falls. These are all events that are very unpatient-centered. Patients don't want them and are very costly. And previously, if this happened while, if a patient got a hospital-acquired infection, they just stayed, 10 or 20 days longer to be cured of this infection, hopefully, and the hospital was able to bill for those extra days. Now, Medicare said, if the patient has this event while in the hospital, then you should have taken steps to prevent it, and therefore we're not going to pay you for the additional care that's required associated with a never event. So this is one major focus of hospital value-based purchasing. Physician value-based purchasing has tended to focus on something that we call best practices care. So can you document, usually through claims, that you have delivered the best practices care for this patient with diabetes? So, for example, have you tested their hemoglobin A1C at least once every 6 months, once every year? Have you done, diabetic retinopathy screening? Have you done diabetic counseling, etc. So there are certain practices that are often defined by the specialty societies as best practices. They're services. They're not outcomes. They're generally services, and they can be documented usually through claims. And physician value-based purchasing says you have to document that 80% of your patients with diabetes got these 5 best practices care, and then we will give you a financial bonus. Okay. Again, I would argue that while value-based payment has some positive impacts on quality of care and patient outcomes, so moving a little bit more towards patient-centered, individual-centered, it still relies on a deficit-based view of health. You have to be in the hospital you have to come to the hospital to get that care. If you never come in, you're not included in that value-based payment strategy. And physician value-based payment very much focuses on what are best practices for these illness-based patient groups, and very, very little focus on healthy populations and keeping them healthy. So, last one I'm going to talk about that some might raise as a potential solution to the shortcomings in our healthcare system, HMOs. HMOs are actually older than either of these two innovations, as we call them. They're from the 70s, 1973, the HMO Act of 1973 from Richard Nixon. What is an HMO? It stands for Health Maintenance Organization. You're like, great, it actually is focusing on health. Well, I would argue maybe not. So what is it? HMOs get paid a full, a payment per member per month to provide all the necessary care. In fact, I should have put in there all the medically necessary care. So you hear that term again. And what is happening is that the risk is shifted to the provider to think about where should they invest those dollars. So there are some incentives for maintaining health, but really this is still built on the chassis of our deficit-based healthcare system. And in fact, a real problem is that people don't stay in HMOs. They're in a particular HMO for 2 to 4 years, and then they go somewhere else. So the HMO's incentive to invest in the health of that individual is really limited to anything that can have a relatively quick return. And a lot of our prevention is much longer. If you want to invest in healthy children, that pays off over a lifetime, not in the next 2 to 4 years. So it also really still emphasizes that provider-centric care and medical necessity. So it is not really, it's better, but it's not really the transformation that I think we need. So I would argue that the change we need is fundamental. Our US healthcare delivery system revolves around providers, not persons. It's the wrong focus. Our finance revolves around a deficit-oriented concept of medical necessity, not the protection of health. Our US healthcare system revolves around health care, not health. So, based on this historical perspective, you can see that our healthcare system is really, it's a serendipitous and it's an accidental system. It was created to address the needs as they presented themselves in history. It was driven primarily by political power and special interest. First, soldiers and their families. Then over time, the military, then the AMA, and that's a whole other talk. But a lot of our system was simply driven by the loudest voices, not the quietest ones, not the ones that we really needed to pay a lot of attention to. And I would argue the last 50 years have been the most rapid change in our healthcare system, and we've been working to address the shortfalls in that system for more than 50 years. Okay, so just a thought experiment, a few slides on thought experiment, and then I welcome your thoughts on this. What might a person-centered system look like? My little person here. If health were defined as complete well-being, physical, mental, social, if health were a right and not a privilege, not the privilege, if you have money, you can get health, otherwise you cannot. If our system focused on the individual and what the individual needs, with the support, of course, of their family and community, and what the individual defines as their health goals. These hands, the family and the community supporting the individual as they choose. What would it look like if we focused on strengths and built from strengths, not deficits and ameliorating deficits? What would it look like if we had a full complement of health and social services available to support the individual's health goals? All right, so everything coming into the individual. I'm struck by how our system has the provider at the center, and we have to come in and we have to find our way in. Instead, what if the individual within their community was the center and the health and services, social services came to find them? Many of you might say, well, wait a minute. What about cost control, evidence-based care, quality of care, all the things that have been the focus of our health system reforms for the last 50 years? I would argue with you that the perfect healthcare system doesn't exist, but we have one that started with the wrong center. Could we not make a better system that was person-centered, that would support health, not health care, that would focus on strengths, not on deficits, that address cost, quality, and outcomes, yes, but from a new starting point? So address cost. We do need mechanisms to control costs. I'm an economist, I will not argue with that, but our priorities for how we control costs would be very different. Right now, we control costs by using this term medical necessity. It's a deficit-based concept. What if we said, no, the bar, the standard for addressing costs is, does it support the individual's goal for their health? Can we consider spending our dollars holistically, looking at the full complement of health and social services that are critical for protecting and promoting health? instead of separating them so completely the way that we do this in the United States? Can we support evidence-based care and quality? So evidence-based care, yes, we need knowledgeable providers. I'm the first to say I want a knowledgeable provider taking care of me, but they need to be our partner, not our decision maker. And thinking about models that do that. And then science, we need the science to continue to help us to drive, better ways to deliver care, better treatments, etc. But can it focus on the issues and the questions that are a priority to individuals, not to payers, or at least prioritize individuals over payers? I know you're looking at me and saying, wow, just very small questions you're asking here. Well, is this really a dream that's too big to do? I want to just inspire you a little by sharing a few quotes that I like to think of when I think about really big problems. And I think you guys all think about really big problems. So if your dreams don't scare you, then they are too small. So if this scares you, good. It should. That doesn't mean that we don't do it. Between the great things we cannot do and the small things we will not do, the danger is that we do nothing. And I think that all the craziness that we have had in our healthcare system has really, in many ways, attenuated our willingness to engage and to really lean into a major reform. And then finally, one of my favorite quotes: "A dream you dream alone is only a dream, but a dream you dream together, that can be a reality." All right. So I am going to now, basically open it up for questions. I would love to hear your thoughts on where we can start with this. I see are there some questions in the chat?
We do have some questions in the
Very
chat.
good.
Our first question that we had was from John Hilton, which says, if we spend so much and outcomes are so little, why is it not changing?
Yes, that's an excellent question. I think there are many opinions as to why that might be. I might suggest that there is so much money in healthcare that there is a lot of special interest and a lot of people protecting their areas that's paralyzing. And it's very, very hard to consider and to discuss wholesale change when everybody has very different goals, and a lot of that has to do with protecting their turf.
We also have I believe it's a question and a comment. Would it be better if we at least stop adding more expenditures on areas that changes so little so far, or even for the worse? It seems adding more tend to encourage higher costs in efficiency.
Yeah, you're not wrong, and I would two comments on that. One is there is a major movement to what's the word that they use? Basically, stop doing stop paying for and de-implement. That's the word I was looking for. De-implement practices and programs that have very little positive impact. And so there is some of that happening, and that's a very good movement. But the other thing that I would say is many times the impact of a treatment or a program is heterogeneous. And so maybe on average, populations don't benefit, but there may be some who benefit, and we don't know which some that will be. And so we tend to err on the side of providing it to anybody who can access it financially, or the physician recommended it. even when, as a whole, that's probably not the best investment of our money.
All right. We have another question. Is prevention a medical necessity?
Very interesting. You're asking me to be more precise, and I appreciate that. I would say that insurance companies can occasionally deem prevention to be a medical necessity, but in general, that term tends to be construed as a relatively short-term concept with impact on function in a short period of time, and is often, interestingly, related to how much it's going to cost. So I would just, not to overshare my health history, I'm a long-term migraine sufferer, and it was very interesting to me that 9 pills a month was medical necessity for migraine treatment, 9 triptans. Where it was never clear to me why I was only allowed to have 9 migraines a month. If I happen to have 15, that was not a medical necessity. So medical necessity has been a very conveniently and inconveniently defined term that often didn't have a large basis in evidence.
Mm. All right. So we have another question. So who do we need to go after to stop this price gouging in the name of our vulnerable population that we serve?
That's the $1 million question, isn't it? I alluded to this, the loudest voices in the room, when we really need to be listening sometimes to the quietest voices in the room. Our system is not designed to gauge resources according to need or restoring a level of wellness, but instead to some of the loudest and some of the wealthiest voices. So some of the best funded healthcare is for males of working age. Sorry, don't mean to offend any. And the least is for, I will draw your attention to mental health care, sickle cell disease. These are conditions that strike very underserved populations that tend to have quieter voices. What is the answer? You tell me. I'd love, I think this is what we need to be thinking about, is that how we change the conversation.
I think that moves into the next question from Scott. Thinking about mental health evidence-based practices, but I can't call up which ones are more focused on strength building. Which ones am I missing, or what more should be developed?
Well, I'm the economist and not the mental health care professional. I think that is a great conversation as to what is our balance of the way that we provide mental health care. Is it very deficit oriented? Again, sort of harkening back to the way that our healthcare system developed, or are we in thinking about building from strength and maintaining health, so to speak? I'm sorry, that's can I call on somebody to discuss that? I think that would be a better way to answer that question. Everybody's muted.
Yeah, I'll give space for anybody who would like to unmute and speak to that question.
You have to leave the silence. I've learned this in my classes. Leave the silence until somebody becomes willing to speak. Well, then I guess we'll just toss it back to all of you to spend some time thinking about that.
Absolutely, I agree with that. Scott. We're back. Scott, do you mind coming off mute and saying what you put in the chat?
Oh, sure. I was thinking whenever we've got evaluation of evidence-based practices, by and large, the measurement in any of those trials is about the reduction of a deficit. So, for example, you say if I'm doing an evidence-based treatment for depression, by and large, it's going to be, did a PHQ-9 score decrease? And there's really not, a PHQ 10, 11, 12 that says, are you getting better at a hobby that's helped you make a friend? or have you gotten a job? Or do you have stable housing now? Right? The 9 questions on the PHQ-9 are really looking at your appetite, your anhedonia, your sleep, and whether or not you've had thoughts of ending your life. There are a few others, but I'm just trying to, in my brain, think about which of the evidence-based practices are explicitly strengths focused. And I'm hoping I'm just blanking and missing something, but I can't call one up.
Yeah, I think you might be right. And perhaps I would suggest that the focus on this type of focus, this deficit focus, is because that's what the insurance companies will pay for, is for you to, reduce depression symptoms, but not to focus on, somebody taking control, being able to find housing or find a stable employment.
If I look at
Well,
the gains and ANSA as potential outcome measures for whether an EBP is effective, that's the kind of thing that makes a lot more sense than a reduction in a PHQ-9 or, a GAD-7 for anxiety.
Yeah.
Thanks.
There was somebody else who was saying something. No?
I believe it was Crystal.
oh, I was just gonna say, like, even if you take a look at our CANS tool, we're doing a lot of rating to see if anything exists and if we need to take action on anything. But there are some strength-based ratings in terms of like what else can we build, what skills and strengths can we build upon and utilize to kind of combat these deficits or to build a working action plan. So it can be looked at as a practice or a tool that we can use that is strength based. But in order to utilize the strengths, we have to know the deficits. We have to know which strengths to put in action. So we could see the tool as a balance. Yes, we're looking for deficits to make sure that we provide action for those and address them. But also we do talk about the strengths and what can we build up. So, I mean, it can be both from a strength-based perspective as well.
Very good. Yeah, great. Well, I think we have time for a couple more questions. It is possible to treat healthcare as a commodity. So people vote for a cost-efficient product with their wallet. Yes, that is a lot of how our healthcare can be treated. So unsavvy providers who jack up prices or engage in the arms race could bankrupt themselves because people would seek and pay for care from more appropriate providers. In theory, this brings on my other sort of health theories, health econ theories that I didn't talk about, but part of that argument relies on people being able to evaluate the impact, effectiveness, quality of different services, to be very knowledgeable in their choosing of providers and choosing of services. And I would argue that in many ways we rely on clinical providers, other providers to be our agents in that choice. And so it becomes much harder for what in essence there was, let competition fix it. I think that our healthcare system, the delivery of health and healthcare services is a very imperfect market. I'll use market, where we don't have perfect information, and it's very hard for us to to select the best service for the particular situation that we personally have. So we need that partner. I'm going to go ahead and move on because I know we're running out of time. Now that we mention it, the measure of effectiveness for the EBPs, evidence-based practices, tends to be self-report by deficit, exactly, the PHQ-9. Maybe that's why measurement matters as much as the treatment. You won't get any argument from me there. I was trying to make sort of this 30,000-foot argument that our system was very much based on deficits, and that if we would think about things from a different vantage point, we might see what kinds of changes we might need in our healthcare system. All right, last one from Mark, somebody I know. Sorry, I might know some of these other people too. Oh no, I have 2 questions. Well, Mark, I spend more time in CW. What is CW?
So child welfare. So just mainly
child
kind of
welfare, sorry.
child welfare system. You do have examples of things that people have created that are evidence-based, that are strength building, but it is, applying that in mental health systems. I couldn't think of one similar to Scott, that off the top of my head.
Yeah, but I think it's very effective in child welfare. And I would argue that part of the reason that that's been more heavily adopted is because you're more likely to bring health and social services together in a holistic way for looking at for the benefit of the child. And I think that's really important. We are one of the only systems in the United States where we have basically heavily divorced those 2 systems of care, and not to our benefit. Last, and then we'll wrap up. Everyone knows that healthcare in the US is expensive, but there are many ways to access healthcare. Many people are unaware of the variety of approaches, so they may end up going down costly paths. Agreed. I think we need to lower barriers to access various resources. I agree with you, but the devil's in the details, right? How do you lower barriers to support individuals finding the best path, and not trying a lot of other things that aren't valuable? It's navigating the system is very hard, and providing navigators to navigate the system can be expensive. So I think that's a good concept, but we've been very challenged to do that. All right. Anything else before we wrap up? It's been great to see you guys. And I welcome additional questions. I'm going to put my email in the chat. It was great to see all of you, and thank you for having me. I always like diving into a room full of people who may or may not think like I do, and engaging in a discussion about how we can make our world a better place.